Question. A 25-year-old woman presents to the emergency department with acute onset right lower quadrant abdominal pain and vaginal spotting. She reports her last menstrual period was 6 weeks ago. On examination, her vital signs are stable, but she is tender in the right lower quadrant. A urine pregnancy test is positive. Transvaginal ultrasound reveals an empty uterus and a 3 cm adnexal mass on the right. What is the most likely diagnosis? A. Ruptured ovarian cyst. B. Acute appendicitis. C. Ectopic pregnancy. D. Pelvic inflammatory disease. E. Ovarian torsion. Correct answer is C. Ectopic pregnancy. This patient's presentation is classic for an ectopic pregnancy, a condition where a fertilized ovum implants outside the uterine cavity, most commonly in the fallopian tube. Key features supporting this diagnosis include: positive pregnancy test. Confirms pregnancy. Empty uterus on ultrasound. The absence of an intrauterine pregnancy in the context of a positive pregnancy test raises suspicion for an ectopic pregnancy. Adnexal mass. Suggests the presence of a tubal pregnancy or a related abnormality in the adnexa. Right lower quadrant pain and vaginal spotting. These symptoms are classic for an ectopic pregnancy, particularly in early pregnancy. Why not the other options? A. Ruptured ovarian cyst. While it can cause sudden lower abdominal pain, it would not typically present with a positive pregnancy test or an empty uterus on ultrasound. B. Acute appendicitis. Appendicitis can present with right lower quadrant pain, but the presence of a positive pregnancy test and vaginal spotting makes this diagnosis less likely. Appendicitis does not explain the adnexal mass or empty uterus. D. Pelvic inflammatory disease, PID. PID typically presents with bilateral lower abdominal pain, fever, and cervical motion tenderness. It would not explain the positive pregnancy test or the adnexal mass. E. Ovarian torsion. Ovarian torsion can cause acute lower abdominal pain and an adnexal mass. However, it does not explain the positive pregnancy test or vaginal spotting. Diagnostic steps. Serum beta-HCG levels. Serial measurements can help confirm an ectopic pregnancy. If beta-HCG levels are greater than 1,500 μ/ml and no intrauterine pregnancy is seen on ultrasound, ectopic pregnancy is likely. Transvaginal ultrasound. The gold standard for detecting ectopic pregnancies. Findings may include an adnexal mass or free fluid in the pelvis indicating rupture. Management. Unruptured ectopic pregnancy. Methotrexate therapy is used if the patient is hemodynamically stable, the ectopic mass is less than 3.5 cm, and beta-HCG levels are less than 5,000 μ/ml. Ruptured ectopic pregnancy. Emergency surgery, laparoscopy or laparotomy, is required if there is hemodynamic instability or signs of rupture, e.g., severe pain, hypotension, free fluid on ultrasound. Rh immunoglobulin. Administer if the patient is Rh negative to prevent alloimmunization. Key learning points. Always consider ectopic pregnancy in any woman of childbearing age presenting with lower abdominal pain and a positive pregnancy test. Transvaginal ultrasound and beta-HCG levels are critical for diagnosis. Early recognition and treatment can prevent life-threatening complications like tubal rupture and hemorrhage.